Yeah, this is a method that is less known than late enhancement CMR. So late enhancement CMR has been known for now 3 decades as the gold standard to image scars in patients. Late iodine enhanced CT is exactly the same principle. So you inject iodine instead of injecting gadolinium. And at the late phase, a bit earlier than on MR, we usually image at 8 minutes post-contrast, you image the heart. And the idea is that the iodine will accumulate in these scars because there are fewer myocytes. It's a matrix of collagen with very few cells. And these contrast media, gadolinium or iodine, have a higher concentration there because there's less cells. These are extracellular tracers, so they accumulate. And then you can see this contrast. So the issue with CT is that it's a bit more noisy than on CMR. You can see here an anterior infarct with no reflow. It was a recent infarct. Here an inferior infarct. Here an intramural scar, and here a subepicardial scar. And there's a little bit more noise. You see the comparison to CMR in this patient with non-ischemic cardiomyopathy or in this patient with infarct. There's a bit more noise, but there's a higher spatial resolution. You take advantage of the spatial resolution of CT, which is 0.5 millimeter. And maybe we'll get to there later, but the artifacts from the ICD is much lower than on MR. There's just the lead that is hampering a bit the septal assessment, but for the rest of the heart, it's okay.
So is LIE on CT needed for all patients, or does it vary?
No, it varies. So as I said earlier, the arterial enhanced CT, so the classic cardiac CT during the first pass of iodine, does the job for most patients. In fact, it's important to understand when these additional methods, late GAD-MR or late iodine CT, are needed because they are less available and sometimes tricky to acquire, either because there's an ICD or because of the renal function, because the late enhanced CT requires additional iodine contrast. So in patients with renal dysfunction, it can be a bit problematic. So our strategy to define the optimal protocol is this one. So in post-infarction, the arterial enhanced CT does the job for most patients, and you will be able to work in your lab with wall thickness maps, fat maps, calcification maps. In ARVC, it's the same. The arterial enhanced CT does the job because we can map the anatomy and also the intramural fat in the right ventricular wall. But it's in non-ischemic cardiomyopathy that you need this contrast within the wall with either late CT or late MR, because the arterial enhanced CT can be totally normal. You won't be able to detect these intramural or subepicardial scar if there's no wall thinning associated to it. So we add this late CT or late MR in NICM almost only, because it provides a perfect assessment of the substrate. And we render these in the form of maps of late enhancement, dense scar, and gray zone to understand the channels of gray zone that may be pro-arrhythmogenic.